Hello, everyone, and welcome back to the 3P seminar series brought to you by the Cure Parkinson's Trust, the Van Andel Institute, and the World Parkinson Coalition. My name is Neil Chatterjee. I am a former 3P alum, and I am currently a fifth-year graduate student at Rush University Medical Center in Chicago, Illinois. It's an absolute pleasure for me to have organized this month's 3P seminar series and bring you this session. Throughout the course of the seminar series, we've spent a lot of time focusing on basic science research in Parkinson's disease. And so today we're shifting gears a little bit and turning to clinical research and having some presentations and talks from clinical researchers at various stages in their training and their research careers. So really excited for the presentations and talks to come. A few housekeeping notes before we get started. The first thing I wanted to turn to everyone's attention was the Grand Challenges in Parkinson's Disease and Rallying to the Challenge Conference being held by the Van Andel Institute in partnership with the Cure Parkinson's Trust. That conference will be held on September 23rd through the 25th, held virtually. This year's conference theme will be when and how does Parkinson's disease start? So a terrific lineup and slate of speakers and some really engaging virtual content for everyone to tune into coming up. With that, I would also like for any new 3P seminar attendees to look to the bottom of your screen where you see the question and answer session. For any of today's speakers or presenters, if you have questions that you would like to ask or raise a topic of discussion, feel free to fill out that question and answer form. And at the end of their presentations, we'll try to get to as many of those questions as possible. And if they can't get to those questions, then we'll try to continue the conversation and discussion on social media, either on our Facebook page or on Twitter afterwards. And so with that, we're going to dive right in. Our first speaker is Michelle Tosi. She is a research fellow at Rush University Medical Center. And today she's going to be talking about clinometrics and developing clinical rating scales for Parkinson's disease. And with that, take it away, Michelle.
Thank you, Neil. Let me share my screen with you. So, okay. So I would like to thank you very much for the invitation to participate in this monthly seminar. Especially for us beginners in the research career, this is a great opportunity to present and discuss our research. So I would start saying that developing a new rating scale can be very challenging, given the combination of qualitative and quantitative methods needed for the creation of a rating scale and the requirements for clinical and research applications. During this presentation, I will explore the methodological steps for the development of a new rating scale and the requirements for assessing the clinometric properties of a rating scale. The Parkinson's Disease Medication Adherence Scale, the PDMIS, will be used as an example of how we can exemplify these steps that aim to create a scientifically and sound and reliable scale that can be used for clinical and research purposes. So in order to guide our discussion, throughout this presentation, we will seek to answer these two guiding questions: why develop and how to develop a rating scale. And let's start with this first one. Why develop a rating scale? So for more than 100 years, nations have collected statistical data characterizing social conditions. These data, as an example, birth and death rates, education, crime, housing, employment, reflect issues of public concern and have often become the focal point for movements of social reform. But the debate on measuring health phenomena can be much more complex and abstract, given the nature of health itself. The summated rating scale is one of the most frequently used tools in the social and health science. Historical records attribute the first psychometric records to the 80s, but the invention of the rating scale is attributed to Hensis Likert in 1932. Who described the use of a rating scale for the assessment of attitudes. These scales are widely used across the social and health sciences to measure not only attitudes, but opinions, personalities, and descriptions of people's lives and environments as well. Scales presently exist that measure emotional states, for example, anger, anxiety, and depression, personal needs, for example, achievement, autonomy, personality, for example, locus of control and introversion, and behaviors, for example, medication adherence. In compiling this health data, clinicians and researchers can identify a constellation of variables that comprise the human responses to a specific illness or event. And that's why scales are used as instruments to measure the health phenomena that will guide interventions and treatments. Nowadays, scales are the ubiquitous topic and method. In an amputation search at PubMed, we retrieved more than 160,000 search results using the term rating scale. And convinced that by isolating and measuring specific attributes, the more systematic approach to identify the presence of attributes in a specific population can be achieved using rating scales, we ask ourselves, how can I create a rating scale? So the development for a rating scale have several methods, and they are used to present the necessary steps for the development and the validation of a rating scale. And for the PGMIS, the scale that we are developing, we are choosing the methods proposed by Benson and Clark. In this method, there are 4 phases and up to 13 steps necessary to complete the process of developing and validating a new rating scale. Specifically in Parkinson's disease, the method proposed by Stebbins and colleagues is widely used, and it is possible to establish congruence between the steps proposed by these authors. And for this reason, I will present you both methods. So, the development of a new rating scale begins with a good planning, where the researcher will determine the purpose of the scale, will determine the target audience and the domain of interest to be measured. Taking the PGMIS as an example, in this planning step, we reviewed the literature and identified 2 important theoretical foundations for defining the domain medication adherence. The first one is proposed by the World Health Organization that establishes 5 subdomains related to adherence behavior. And the second, proposed by the ABC taxonomy, which established the behavior of an individual in relation to the different stages of the medication adherence process. Based on these fundamentals, we conducted a systematic review to analyze whether these fundamentals are being covered by the rating scales used to measure medication adherence in patients with Parkinson's disease. The results of our study revealed weaknesses in the scales currently used, confirming the need to create a new rating scale. So at this stage, we need to confirm if a new rating scale is relevant at this point. And considering the complexity of the disease and its treatment, we continue in this stage by conducting focus groups with patients and care partners. The straight hand of our study is that these focus groups were composed of people residing in Brazil and United States, which expands the possibilities for generalizing the data. And why is the focus group so important at this stage? Because through the focus group, we can collect information directly from the population of interest through open questions and guided discussions, which will be transcribed and then analyzed through framework analysis. These results will then be presented to a panel of experts and patients representatives, the Delphi panel, who will use all this collected information to define the domain and its subdomains of the rating scales based on their clinical experience and knowledge. At this point, they will determine the consensus of the domain of interest through the consensus validity ratio, With that, we have completed phases 1 and 2 proposed by Benson and Clark, which can take 1 to 2 years to be implemented. In phase 3, we have a first version of the rating scale, which needs to be tested. Cognitive pre-testing is the recommended method at this stage, and it will provide information of comfort with use, understandability, comprehensiveness, difficulty wording, missing items. No numerical analysis is done here, being the data analyzed in a purely qualitative way. Usually, we use small samples of patients and raters, less than 30, who will be asked to analyze the scale. During this reading, the researcher will be able to apply 2 research techniques: talking aloud, which consists of observing difficulties with rating scales while reading the questions and answers, and focused interview, which consists of asking specified questions related to the rating scale. The responses should be recorded and transcribed in verbatim. After completing this phase, we move on to the last phase of the development and validation process. In this step, the second version of the rating scale is tested and its clinimetric properties are analyzed. But on the clinimetric properties, I will talk a little bit later, because now we would like to highlight the relevance of identifying, measuring, and maximizing the clinical meaningfulness of a rating scale. And for that, we need to understand who, when, and how you assess the domain of interest in a rating scale. And to identify and maximize clinical meaningfulness, you need to be clear to whom and when the domain is being measured. So in Parkinson's disease, what we observed is that as the disease progresses, this is an increase in the number and the severity of symptoms and a decrease in the functionality and quality of life of patients. For this reason, drug treatment needs to be constantly educated and modified in order to meet the needs of patients in the face of the disease. It is therefore expected that in this population, which answers our first question, who, the domain of medication adherence needs to be constantly reassessed, and it answers our second question, when. Because with each change in the therapeutic regime, there is an increased risk for non-adherence. In doing so, we identify and maximize clinical meaningfulness. With that, we follow in accordance with the recommendations of regulatory agencies, such as the FDA, which has valued the experience of patients and care partners in conducting research for the formulation of drugs and medical devices. According to the FDA guides, the level of insight required by stakeholders varies according to the domain that is intended to be studied, with the need for a greater patient participation when the instruments to be developed requires more information about the patient. Taking the PDMIS as an example, medication adherence is a behavior composed by multiple factors, consistent both with patient's lifestyle and characteristics of the therapy that positively or negatively impact the patient's ability to follow the prescription. Based on this, it is very important that when conducting investigations, we, as researchers, listen to the patient's voice. And to measure clinical meaningfulness, we need to know how we do that. And this is where I address the clinimetric properties of a rating scale. In the process of validating a rating scale, we can conduct several statistical approaches. And it is recommended that this be done in a large sample field testing. I could say that this phase will never end, as the scale will need to undergo several improvements over time. And thinking about the statistical approaches, we can ground on two theories: the classical test theory, the CTT, and the item response theory, the IRT. The framework for IRT differs from CTT in that the measurement characteristics of the scale are calibrated to a sample independent latent model of the domain. Whereas CTT approaches may demonstrate items clustering into a single factor relating to the total score on a rating scale, the IRT approach examines the relationship of item scoring to a latent model of the domain. This approach allows for person-invariant examination of item and scale score relations to the magnitude of the latent trait. Importantly, if items or item clusters chart the domain differently than other items or clusters, IRT will identify these patterns, allowing clinicians to consider strategies of data analysis to rectify the statistical discord. So we have several statistical approaches that can be applied at CTT, and they aim to measure the reliability and validity of an instrument. As an example, I can mention the techniques for assessing the scale's internal and external validity, its predictive capacity and sensitivity to change over time. So these slides will be available for you to study carefully each of these techniques. At IRT, we use other techniques and analysis parameters that I can see here to you is the item characteristics curves, the ICC. Through the ICCs, discrimination parameter, we can analyze how powerful an item is in determining the individual's overall latent trait, while the threshold indicates the probability for transitioning of an item score in relation to the latent trait measure of overall domain. And here we are referring to a Likert scale. But we are talking about clinical meaningfulness, and there are other important approaches that can be used to measure this. Global impression provides a global impression of clinical meaningful change when directing the question directly to the patient, while the performance-based approach assesses lesion behavior, and natural language process analyze clinical meaningfulness via natural language processing by asking patients what is important at a given point of time. And I would like to end this presentation with some take-home messages, emphasizing that rating scales are a ubiquitous topic and method, that a rating scale provides a proxy measurement to real events, and that for these and other many reasons, developing a new rating scale can be an overcoming challenge if the required phases and techniques are understood and implemented. In doing so, we will be able to create rating scales that are scientifically sound and reliable, and that can be used for clinical and research purposes. I would like to thank you all for participating in this pleasant moment with us. And I would like also to thank all the partners who support this research. And once again, thank for the Cure Parkinson's Trust for the opportunity to be here. And remember, everything that exists in some quantity and can therefore be measured. Thank you so much.
Thank you very much, Michelle, for a really, really interesting conversation. You know, we use disease rating scales, so many of us from the research community, but what actually goes into developing a research scale, I feel goes over the top of a lot of our heads. So really fascinating thing to dig into. I think we have a question, maybe time for a question. I guess one of my questions is, how adaptive are rating scales, and what's the timeline as you are going through these revalidation steps and making sure that the scale has the integrity to a patient population? How long does it take for reevaluation of a rating scale, and what is that timeline before something becomes more clinically applicable?
Yeah, that's a good question, and I could say to you that the rating scale reanalysis needs to be done at every moment that we analyze a context of patients, and we can see that some of the changes in the context on this environment is occurring. So that means that we are every time reanalyzing these rating scales as the complexity of the disease is in progress, in constant progress. So for example, in Parkinson's disease, every time we can discover another symptom related to another symptom. So that scale that is investigating that symptom, is that scale really measuring this predictive, is really measure that domain. So I know that's crazy, but we are in constant development of a rating scale, and this needs to be a point of discussion from everyone.
Sure. Well, thank you very much. It's a very difficult moving target, but it's very necessary information, obviously, for everyone in the research and clinical community for PD. Thank you so much for that presentation. Really interesting work. Our next presenter is Dr. Gian Pal from the Robert Wood Johnson Health Center at Rutgers University. And today, Dr. Pal will be talking to us about Parkinson's disease and DBS and the cognitive effects of GBA mutation carriers. And so with that, I'm going to toss it over to you, Dr. Pal.
Thanks so much, Neil. I'm just getting set up here to share my screen. Okay, thank you so much for giving me the opportunity to speak today. My name's Gian Pal. I'm at Rutgers University in New Brunswick and part of the Robert Wood Johnson University Hospital. And today I'm going to be talking about Parkinson's disease and deep brain stimulation, cognitive effects in GBA mutation carriers. Here are my disclosures. Some of what I'm going to be talking about today is related to my K Award, which you see listed there. So my objectives for this talk are to define the indications for DBS and Parkinson's disease. We're going to then talk about some of the common PD genes that are enriched in the DBS population and their potential value in understanding DBS outcomes. And then I'm going to talk about areas of current research that I'm involved in and also future directions for DBS and genetics. So deep brain stimulation is a well-established treatment for movement disorders. It's a fully implantable neurostimulation system, basically like a pacemaker for the brain. It works very well because it's non-destructive and reversible, so there's no lesion created per se in the brain. And it works by altering the abnormal basal ganglia circuitry. It's programmable and adjustable, so you can maximize the benefits and minimize adverse effects. The indications for DBS for Parkinson's disease specifically include tremor, bradykinesia, which is slowness of movement, rigidity, dyskinesia, which is this kind of wiggling movement that you might see Michael J. Fox having when he's presenting sometimes, and motor fluctuation. So whether or not medication is working reliably for the patient, patients may have a lot of up and down in terms of their medication functionality, and DBS can smoothen out that motor function. Things that typically don't improve with DBS include speech, dysphagia, small handwriting, freezing of gait that is prominent when the medication is when the patient is in the on state, balance problems, cognitive dysfunction, or dysautonomia. And so this is a paper that was published by Gunther Deutschel in the New England Journal of Medicine, where really was a seminal article showing that DBS really is effective compared to traditional pharmacologic or medication management. The top panel, panel A, shows that patients who were randomized to bilateral deep brain stimulation had significant improvement in multiple domains of quality of life compared to those who received medication treatment alone. And then in the bottom panel, you can see that patients spent more hours in their day in their on state, so their good time, they had more good time without troublesome dyskinesia compared to those who had just medical management. And so I'm gonna try to, hopefully this will work, I'm gonna show a video of a patient who's had deep brain stimulation. And you can see pre-DBS, this is the patient in the off medication state. You can see he's got tremor. And I'm gonna just try to fast forward through this in the interest of time. You can see he looks a little bit uncomfortable. He's stiff, he's rigid. And when he does his movements, he's slow. So now, and here he's having trouble standing up from a seated position. He's slow with his walking. And now let's see him with his medicine on board. And now you can see he looks a little bit more comfortable. The tremor's resolved, but he's got a new problem. He's got dyskinesia. He's got some extra movements. And interestingly, even though he had pain in the off condition without the medicine, he's actually uncomfortable and has pain in this state as well. And that's because of these neck movements that he has, which are quite uncomfortable. And so this gentleman was, really between a rock and a hard place. Without the medicine, he was uncomfortable and had difficulties with mobility. And with the medicine, he had too many movements and also was uncomfortable because of the excessive movements in his neck. So this gentleman decided to undergo bilateral STN deep brain stimulation. STN is one of the targets that we use. And here you can see that he's much more comfortable. You can see he is just a little bit more expressive. He has no tremor. He doesn't have any of that excessive movement. And here he's still a little bit slow, but he's only relying on the stimulation to control his movements. So with a little bit of medicine, he's actually even better than this. And then you can see that he walks pretty well. So this is just to illustrate that deep brain stimulation is really a powerful tool that in the right candidate can really be life-altering for Parkinson's disease. And so one of the things that we have to decide when we see these patients is which target in the brain to select, the subthalamic nucleus or the globus pallidus interna, okay? And both targets have their pluses and minuses, but I think most neurologists tend to favor the subthalamic nucleus. And the reason for that is that the subthalamic nucleus gives a significant improvement in motor benefit and allows patients to reduce their total medication burden significantly. And this study that was done by our Dutch colleagues, Ouderkerken et al., which was published in Lancet Neurology, shows that patients who were randomized to STN versus GPI at 12 months did really quite well and quite similarly regarding their activities of daily living. So what you can see is this weighted ALDS score, which is in the top row, was really the same at 12 months for the STN versus GPI group. So they had they did very similarly and actually favored the STN group to some degree. There was a trend towards favoring the STN group, which the Dutch group mentioned. Now, there are other studies which prove something similar, that STN and GPI are similar for motor outcomes, but may not be equivalent in terms of cognitive outcomes. This is a randomized study from the VA, the VA cooperative study on DBS that was published in Neurology some time ago. And these subjects were randomized to STN versus GPI. And you can see that at 36 months, motor function improved for STN and GPI in a similar fashion and were stable over time between the two groups. But the last line that I've underlined, the MADRS Dementia Rating Scale scores actually declined faster for the STN group compared to the GPI group, okay? So even though these patients might benefit from less medicine with STN, they might be at further risk for cognitive problems, which are target specific. And so we know that in seeing these patients, the outcomes for DBS can be heterogeneous. Patients can suffer from depression, apathy. I talked about cognition in terms of verbal fluency reduction or executive dysfunction. They can have impulse control disorders, anxiety or mania related to DBS. And so one of the things that I wanted to try to understand is, where does this heterogeneity in outcomes come from? And there was this very interesting article that was published by the group in Queen's Square by Tom Fultony and Patricia Limousin, and showing that there's significant heterogeneity in DBS outcomes because Parkinson's is a heterogeneous disease, and genotype may be useful in predicting the phenotype in these patients. Very interestingly, they genotyped 94 patients who received DBS, and 27 of those patients, of that 94 patients, had a mutation in at least one of 3 PD genes. So 29%. That is a remarkable number. I think most studies that you will read will say that between 5 to 10% of Parkinson's patients have a genetic form of disease. And in this study, they had 29%. Well, why is that? Well, it could be that, a lot of patients are kind of self-selecting themselves for this therapy and are more homogeneous in some way, in certain ways, that make them more likely to have a genetic form of the disease. So patients who undergo DBS tend to be younger. They tend to have similar medical problems in terms of having motor fluctuations or dyskinesia. And they tend to be very levodopa responsive. So we're kind of self-selecting a more homogeneous group of patients. And the genes that they tested for were GBA, or glucose cerebrosidase, LRRK2, or Parkin. And so these are the 3 genes you can see listed here. And the highest number was GBA. So 16 patients, which is 17%, had at least one mutation in the GBA gene. And so I set out to reproduce this with Karen Martyr from Columbia and the Core PD data set, which was a large consortium of early onset Parkinson's disease, which studied a large group of Parkinson's patients through this consortium. And what we found is that in the Core PD patients, when we looked at those who got DBS and those who didn't, so we had about 100 patients with DBS and 684 patients without, we found about 12% were GBA carriers versus 8% in the non-DBS group, 5% were LRRK2, and 10% were Parkin in the DBS group. And those numbers were significantly less in the non-DBS group. So we found something that was comparable to what the Queen Square group found. And I set out to study GBA because GBA has important implications for Parkinson's disease. So what is GBA? So GBA is a gene that codes for beta-glucoceramidase, and patients who are homozygous develop Gaucher's disease. Patients who are homozygous or heterozygous have an increased incidence of Parkinson's disease. Those who are heterozygous, interestingly, do not develop Gaucher's disease, but are at higher risk for PD. And GBA mutations are now recognized as the most common genetic risk factor for Parkinson's disease. Up to 1% of the general population are heterozygous for GBA. 7 to 10% of PD patients worldwide carry a GBA mutation. Patients who have a familial history, it can be anywhere from 20 to 30% will have a mutation in GBA. And GBA mutations are also associated, interestingly, with dementia with Lewy bodies. And so we can break up GBA mutations into different types of mutations. We can break them up into mild mutations, severe mutations, and those who are homozygous. So who also tend to have severe mutations, but kind of a double hit because they have two. So the mild and the severe are heterozygous. The homozygous have two severe mutations. So the age of onset for the mild mutations is usually later in terms of Parkinson's disease. For severe mutation carriers, it's a little bit earlier than typical patients. And homozygous have the earliest age of onset compared to typical Parkinson's patients. Survival is reduced in mild mutation carriers, similar in severe. It's unknown in homozygous carriers. There's an increased incidence of dementia in all three groups, more visual hallucinations as you increase in severity, more depression as you increase in severity, at least between mild and severe carriers, more dysautonomia, more RBD compared to mild and homozygous carriers. Mild mutation carriers tend to have more of an akinetic, rigid phenotype compared to a tremor-dominant phenotype. Motor severity, controlling for disease duration, is greater than your typical Parkinson's disease patients. Mild mutation carriers tend to have really excellent levodopa response, and similar for severe mutation carriers. Motor fluctuations are present in this group. There may be more dysphagia, more dysarthria, and more freezing of gait. And typically, the progression or the time that they get to Hoehn-Yahr stage 3 is earlier as well. So from a cognitive standpoint, really, the GBA mutation carriers have an increased risk of dementia. They have an increased risk of neuropsychiatric features and an increased risk of autonomic dysfunction. And so to me, it was very, very interesting that you're taking a group of patients who are highly susceptible to cognitive and neuropsychiatric problems, and then that same group makes up the biggest portion of genetic mutation carriers who undergo deep brain stimulation. And the target that we choose typically is one that may also be associated with cognitive decline. So I thought that it might be useful to use this genetic information to understand whether we can treat these patients perhaps differently and see if they have a worse outcome with STN-DBS, or do they fare just as our typical Parkinson's patients do, or would they fare better with a different target in the brain, such as GPI? And so I know this slide is a little bit busy, but this was some really early data from that Queen Square group data, and they set out to try to show at least motor outcome for GBA versus non-GBA. And so I'm going to highlight a few key things. So you can see in the GBA group, the top circle, levodopa pre-DBS was the same compared to GBA versus non-GBA. Their motor exam, or their response to levodopa, was quite significant and comparable to the non-GBA group. And their dyskinesia scores were also comparable compared to the non-GBA group, and their UPDS Part 4 scores were also similar. Now, when you look at how they did with the GBA group, so only 2 of them underwent GPI stimulation, but when you compare the GPI group with GBA versus the GPI group without GBA, you can see that there was a 22% difference versus 28% there. And their change in Part 4 scores was 94% versus 42%. And from a cognitive standpoint, the mean change in MADRS scores in GBA was 4.4 points per year compared to only half a point per year among mutation-negative patients. So in other words, the GBA group was more at risk for cognitive problems after DBS compared to the non-GBA group. And this was only looking at the STN patients. So there are other studies. There was another study by Lyth et al., which showed that GBA patients who undergo DBS actually earlier in their disease course, either in terms of age at DBS or how long they have the disease durations. They typically have more severe motor symptoms at baseline, and they have a more severe burden of non-motor symptoms compared to the non-GBA subjects. One of the limitations of this study was that they weren't able to really control properly for preoperative data. Dr. Weiss et al. Published a small case series, again showing that the GBA carriers had more cognitive problems compared to their non-GBA counterparts after DBS. I was lucky enough to be part of this meta-analysis that was done by Ari Marola from Cincinnati, where we looked at subthalamic nucleus deep brain stimulation and motor, functional, and pharmacologic outcomes in patients with different types of genetic forms of PD. And what we found is that the motor response was comparable in the GBA carriers, but again, there was a higher prevalence of dementia in those GBA carriers when we pooled all of the data together. I decided that I wanted to start genotyping all of our patients who got deep brain stimulation at Rush when I was working at Rush, and I started pooling data from multiple centers throughout the world, including Queen's Square, Mount Sinai, Columbia, the NIH, and using some of the PPMI data. And when I pooled that data together, we looked at cognitive outcomes post-DBS, looking at STN, DBS in both groups, bilateral, and we were able to pool 30 GBA subjects compared to 44 non-GBA subjects. When you look at things like age of onset, disease duration, years to DBS, years of DBS, baseline cognitive score, and baseline motor function, preoperatively, all of those items were comparable between the two groups. But when we looked at how these subjects did post-DBS, mild mutation carriers had a faster cognitive decline compared to those who had no mutation, and severe mutation carriers also did worse than non-mutation carriers over time. And so why is this? Why are GBA mutation carriers doing worse with STN DBS compared to their non-GBA counterparts? Well, it could be that GBA mutation carriers, that's just their natural disease progression. Alternatively, the STN may be playing a role. We know the STN plays a crucial role in response inhibition during conflict to prevent impulsive actions. When we lesion the STN, we know that patients and animals, non-human primates, move faster but are more susceptible to making errors. So they may have a faster reaction time, but they may make more errors on things like the go, no-go test or the Stroop test. And so what I'm doing in my K award is really looking at 4 groups of subjects. I'm trying to parse out whether or not the GBA carriers are doing worse with STN DBS because that's the natural course of GBA mutation carriers, or is there a interaction between GBA and STN implantation? So we're looking at 4 groups of patients, GBA mutation carriers with and without STN-DBS, and non-mutation carriers with and without STN-DBS. And our first aim, what I'm trying to do is look at longitudinal changes in global cognitive function in GBA carriers, focusing on GBA carriers with the hypothesis that the GBA carriers will have greater decline in cognition over time compared with the other groups. And we're looking at change in MADRS baseline, which is preoperatively compared to year 1 and 2. We're also collecting quality of life data. We're looking at the MoCA, HAM-A, HAM-D for depression and anxiety, motor data, non-motor symptoms, and then also blood samples, so plasma and dried blood spots to hopefully look at GBA metabolites over time to see if those can give us any clues regarding the biologic mechanism as to why this is happening. This is additional data that we're collecting. We are giving the patients their results with genetic counseling. And then in AIM-2, we're using the NIH toolbox with the idea that we want to look at whether certain domains of cognition are more affected in GBA mutation carriers compared to non-mutation carriers. And visual dysfunction is really one of the key domains that has been found to be affected in GBA mutation carriers. So we're focusing on the picture sequence memory test there. And in AIM-3, we want to see whether changing stimulation parameters, in other words, turning the stimulation off versus on, has a direct impact on cognition. So when we turn off stimulation in GBA mutation carriers, can we improve the cognitive function, or does it alter their cognitive function compared to when the stimulation is on? And so I'm also working on another project that we're getting ready to publish where we're looking at differences in physiology to see if there's a physiologic difference in brain waves, looking at GBA mutation carriers versus non-mutation carriers. My plan is to write another grant looking at how GBA mutation carriers do comparing STN versus GPI, because that's another question that my current study won't answer. It's also very important to figure out how to deliver this genetic information to patients in a way that they understand it, so that the family can really digest what this means and whether or not other members should get tested. And then also, I'm interested in looking at other genes like Parkin and LRRK2 and how they may also influence DBS outcomes. Here are my references. Thanks again.
So our final speaker is going to be Dr. Roshni Patel, who is a movement disorders fellow at Rush University Medical Center. And today she is going to be sharing us some data on COVID-19 outcomes with patients of neurodegeneration. So without any further ado, Dr. Patel.
Great, thank you. All right, let me just share my screen here. All right, I'm Roshni. I'm a movement disorders fellow at Rush, and I wanted to share a project with you that I've been working on recently, and hopefully it's topical. It's regarding outcomes in hospitalized patients with neurodegenerative diseases who have COVID-19 infection. So some background. We all know about this, pandemic that's ongoing right now. There have been big cohorts that have been published on risk factors for morbidity and mortality with COVID-19. And some risk factors that have been identified include things like age, diabetes, hypertension, male gender, obesity, things of that nature. The mortality rate is maybe between 1% to 10%, but it kind of varies depending on different countries and factors, populations in those places. And so one question that came up just when this all started, just in patients that I was seeing in the clinic, a lot of people were very worried about this, and they were asking me, am I at increased risk for getting sick with this or dying from this infection? And so a little bit of data has come out since over the last few months about this question. And so basically these are all cohorts that I've listed here of different diseases, and I've kind of listed the mortality rates here. So in Parkinson's disease, there are two published cohorts, one listing 19% as a mortality, another one listing 40%. In dementia, there's two cohorts, and they both list the mortality rate a lot higher at about 60%. And then there's one big cohort from Italy that lists of patients with MS that lists a mortality rate at very low, actually, at around 2%. But I think some limitations with these previous studies. One is that they mostly come out of Europe and Asia, and so of course I'm practicing here in Chicago in the U.S., and so I wanted to know, do these numbers apply to my patients or not? And then another thing is that a lot of these, most of these studies were not controlled, so they were just looking at the mortality rates within these patients, but they didn't look at age-matched controls. So our question in designing the study was, do patients with neurodegenerative diseases have increased risk of morbidity and mortality with acute COVID-19 infection? So this was a retrospective cohort study. We actually got the data from a COVID-19 registry that was set up within the Rush system. And so this was basically a database of all COVID positive patients within our hospital system. And it includes actually 3 hospitals in the Chicagoland area. And the inclusion criteria when we were trying to identify patients for the study were that they should be adults, they should be have confirmed COVID-19 with testing, and then they had to have been hospitalized with COVID-19 within a 3-month period. And we had 2 cohorts. We had a neurodegenerative cohort that was identified based on ICD-10 codes for different neurodegenerative diseases, which I'll show you in a minute. And then we also had a control cohort, which were basically, also hospitalized COVID-19 patients that were age matched to the neurodegenerative patients. And it was age matched by plus or minus 5 years. And then we excluded patients who basically, we call it, had an incorrect neurodegenerative diagnosis. And so basically, because of the way that we identify patients using ICD-10 codes, these codes are not always accurate. And so we actually went through manually and tried to look at the patient's charts and confirm that they truly had a neurodegenerative disease that was documented in the chart. And so some patients were actually removed if they didn't have kind of a verified neurodegenerative disease. So for example, a patient with ataxia, if they had a peripheral neuropathy that was causing their ataxia, they were removed because that was not considered like a degenerative brain disease. The primary outcomes that we looked at were death, intubation, and ICU admission. And these are the secondary outcomes that I'll explain these and describe these in more detail when we talk about the results. So we don't have to review that. This is just an example of all the different ICD-10 codes that we used to identify these patients. So these are all codes that correlate with different diagnoses, and this is what's used in terms of documenting these patients in the chart and for billing purposes. And so all the codes were listed here that we used, and we basically kind of condensed them because there's so many different codes and a lot of them are redundant. We basically condensed them and we came up with this kind of more condensed list. But obviously under each of these categories, there's several different codes that are listed under these categories. And then finally, we used these different statistical analyses to compare the 2 groups. We used t-test to compare continuous means and continuous variables, and then chi-squared and Fisher-Exact to compare categorical variables, and then we used p less than 0.05 to indicate significance. So these were the baseline characteristics of our patients. So we had 132 patients in this neurodegenerative cohort, and then 132 controls that were age matched. And you can see here, overall, they were very similar in their sort of baseline characteristics, their demographic characteristics. So the age was about 77 or 78, basically, that was the average age. 41% were male and they actually, just by coincidence, were exactly gender matched. Their BMIs were similar. They're actually a little bit different, but not statistically different. It was 25 versus 28. And then their medical comorbidities were similar as well. So, many of them had asthma and diabetes. A lot of people had hypertension and cardiovascular disease, so over 90% in both groups. A little bit less than half had chronic kidney disease, and then chronic liver disease was uncommon in both groups, but maybe there's just a few more in the control group. And then in terms of race, we had a pretty diverse group. 46% were Black in the neurodegenerative group versus 35% in the control group. And then about a third were white, and then the rest were kind of belonged to these other groups, or the data was not available. And I think this kind of reflects it reflects kind of the diversity of Chicago, but unfortunately it probably also reflects the kind of what we've learned about this disease, that unfortunately it tends to affect people of color a little bit more commonly and more severely, and probably related to kind of like historical health disparities and things like that, unfortunately. So yeah, and then in terms of ethnicity, this was the only group, this was the only metric that was a little bit different. So the control group had a few more folks of Hispanic or Latino ethnicity compared to the neurodegenerative group. And I'm not exactly sure why this is. I'm not sure if dementia or other neurodegenerative diseases are more or less common in Hispanics or in Latinos, or maybe they're just under-recognized. I'm not entirely sure about that. And then finally, we looked at, we calculated mean income based on zip code. So this was just based on like the patient's zip code. So it's not the patient's exact income, but this is kind of a reflection of socioeconomic status. And basically they were similar between the two groups. These were all the neurological diagnoses of the neurodegenerative patients. So the most common diagnosis was dementia, this kind of unspecified dementia. 14% had Alzheimer's, 14% had Parkinson's, and then only three patients had multiple MS, so not a lot of those patients. And then the rest of these are just kind of other scattered specific sort of types of dementia. And then these were the number of hospitalizations that we looked at. So even though we had 132 patients in each group, some of the patients were actually hospitalized multiple times for COVID-19. And so there ended up being 142 hospitalizations related to COVID in the neurodegenerative group versus 149 in the control group. And these were the primary outcomes. So death was not different between the two groups. Oops. So it was 20% in the neurodegenerative cohort and 23% in the control cohort. Interestingly, intubation was different. So it was actually more common, actually almost double the rate in the control group, about 23% versus 11% in the neurodegenerative group. And I'll talk a little bit more about why in the subsequent slides. And then ICU admission was also similar in the two groups, so 30 versus 36%. One of the secondary outcomes that we looked at was initial COVID-19 symptoms. So what did the patient actually present with when they came into the emergency room and got tested for COVID? So, so these are the different symptoms listed here. And interestingly, the control patients were a lot more likely to present with respiratory symptoms. So like upwards of 70 or 80% of them presented with cough or shortness of breath. They were also a little bit more likely to present with muscle pain or myalgias. Weakness, fever were kind of similar between the two groups. And then the other thing that was very different was altered mental status or confusion. So 60%, almost 60% of the neurodegenerative patients presented and were tested for COVID-19 because they presented with altered mental status versus only 9% in the control group. And then the rest of these symptoms are kind of GI symptoms, which were a little bit mixed, like, some like nausea and poor appetite were equal between the two groups, whereas diarrhea was reported, and diarrhea and loss of smell and taste were reported a little higher in the control group. and then headaches were reported a little more frequently in the control group. And then these are some additional outcomes that we looked at. So length of stay was equal between the two groups, but oxygen use was more common in the control group. So that, if you think about it, that kind of fits with the fact that control patients tended to present with respiratory symptoms more, and they tended to be intubated more. It makes sense that they were requiring oxygen more. Similarly, encephalopathy was more common in the neurodegenerative group, 60% versus 20%. And then neuroleptic use was also a little bit higher in the neurodegenerative group, although it didn't reach significance. One of the things we were wondering is, would code status affect maybe the rates of intubation? And while there was a little bit of a difference between code status with control patients being more likely to be full code on admission, it didn't reach significance, but there was kind of a trend towards that. And then finally, discharge disposition was very different between the two groups. Control patients were more likely to go home, and they were also more likely to go to acute rehab. In contrast to that, neurodegenerative patients were more likely to go to a nursing home with 40% versus 8%. And they were also more likely to go to hospice, so 14% versus 4%. And then these were some of the COVID medications that are listed, and basically they were used similarly between the two groups. And remember, this was kind of early on. These patients were admitted March through June, so I don't think, like, for example, hydroxychloroquine is being used as much, but anyways, it was actually used somewhat frequently back then. Okay, so let's talk about some conclusions. So in our cohort, hospitalized patients with neurodegenerative disease had a similar mortality compared to controls, so 20 versus 25%. And overall, it's actually a little bit lower than what's reported in the literature. Neurodegenerative patients were less likely to be intubated, although they had similar ICU admission rates. And so, as I alluded to earlier, perhaps some of the reasons for this is that perhaps it could be explained by differences in code status, or it might be explained by differences in the reason for hospitalization. So more control patients were admitted with respiratory symptoms, for example. Neurodegenerative patients more frequently presented with altered mental status and confusion, whereas controls presented more with respiratory symptoms, and that's how these are their presenting COVID symptoms. And neurodegenerative patients developed encephalopathy more frequently, but they required oxygen less frequently. And controls were discharged home and to acute rehab more frequently, whereas neurodegenerative patients were discharged to nursing homes and hospice. One thing that we did not take into account with this was we did not take into account where the patient came from. So it's possible that some of these dementia patients, for example, might have come from a nursing home, and that's why they were discharged back to the nursing home. So the signal might not be as high with that part. But so I just wanted to review some strengths and limitations, and then think about some next steps for this discussion. So in terms of strengths, I think one of the strengths of the study is the size of the cohort, the fact that we had age-matched controls, and that we had a kind of a diverse population. Some of the limitations include that ICD-10 based diagnosis is not always the most accurate. We had a very heterogeneous group in terms of the big spectrum of diagnoses that we included in our neurodegenerative group. And then, I think just there are limitations that are inherent to doing like a kind of a chart review type study, just because you're kind of dependent on how things are documented and coded in the chart. And so next steps, there's a little bit more data that would be nice to add, that I had mentioned earlier, where are patients coming from, and was there a change in code status during the hospitalization? We want to do a little bit more analysis. One of the things that would be interesting is look at risk factors for mortality and see if they're different in the neurodegenerative patients versus the controls. And then we might look at some subgroups. So we might pull out the Parkinson's patients or the dementia patients and look at them separately to see if there are some differences within those subgroups. And then an interesting question just in general is, that people are interested in are like, what are the long-term consequences of this infection. And so this would be a different study and maybe a long-term longitudinal prospective study, but it would be interesting to kind of follow these patients and see what the long-term kind of morbidity and mortality would be in these patients. And that's it. So, I can take any questions if you have time, and I just want to acknowledge some of my mentors here and the Rush Bioinformatics group and my dog.
Well, thank you very much, Roshni, for a really interesting presentation with some really interesting data. Obviously, as the data sets grow, the cohort to cohort comparisons and the subtyping of those neurodegenerative cohorts will be really interesting. For the sake of time, we're going to wrap up today. I would like to give a very big thank you to all of our speakers today, and for all of you for joining us at the 3P seminar series. Thanks again to the Cure Parkinson's Trust, the Van Andel Institute, and the World Parkinson Coalition for hosting this seminar series. And be sure to tune in next time in the coming months as we continue to bring more 3P seminar content to your desktops. So take care, everyone.